Thank you for the introduction, and thank you for the opportunity to present. My name is Beatrice, and I'm a general surgery resident. So I'm going to start off with some background on uterine sarcoma and HIPEC, not the two most common things. So uterine leiomyosarcoma is a rare but aggressive tumor that comprises about 1% of all uterine malignancies. It can be difficult to diagnose preoperatively and are often mistaken as benign uterine leiomyomas. When morcellated, they can cause tumor rupture and tumor seeding. And unfortunately, peritoneal recurrence rates are high in these patients, and many patients will eventually progress to distant metastases. The current standard of treatment is surgical resection with systemic chemotherapy, such as gemcitabine and docetaxel. But patients experience toxic side effects, and even with multimodal therapy, the recurrence rates are high. Therefore, there's interest in developing new therapies, such as targeted therapies, and applying cytoreductive surgery with heated intraperitoneal chemotherapy in order to improve disease control for these patients. So this was a 55-year-old who had previously undergone a primary resection for uterine leiomyosarcoma and came to us with a large pelvic recurrence, which you can see this big one here. We offered resection. She underwent surgery, and at 1 month post-op, there was no evidence of disease in the clean scan. But unfortunately, at 7 months post-op, she developed another large recurrence in the pelvis, this time causing a bowel obstruction. And this case illustrates the natural history of uterine leiomyosarcoma and highlights why new therapies are needed. So what exactly is HIPEC and why do we do it? There's actually two components. The first is cytoreductive surgery, so clearing all visible tumor. And that's shown here with a complete peritoneal stripping of the right upper abdomen and of the pelvis. This is followed by heated intraperitoneal chemotherapy, in which heat and the chemotherapy agent work synergistically to eliminate residual peritoneal microscopic disease. So this photo shows the temporary abdominal closure during a HIPEC with the inflow and outflow catheters. And this is the room setup with a patient and the HIPEC machine. But the advantage of HIPEC is that it allows for increased peritoneal uptake of the chemotherapy agent while decreasing systemic toxicity. The role of HIPEC has been described in GI and gynecologic malignancies, as well as in peritoneal sarcomatosis. In particular, for ovarian and fallopian tube cancers, we have clinical trial data that shows the addition of HIPEC has helped improve recurrence-free and overall survival with no increased adverse effects. And that's shown in the red Kaplan-Meier curve in both graphs. The challenge of studying HIPEC in ULMS is the rarity of the disease, as well as the aggressive tumor biology. In this study, 7 patients underwent CRS and HIPEC for uterine sarcoma in the green dotted line, which showed some promise when compared to surgery only in red and chemotherapy only in blue. So our study was a single institution, single arm phase 2 trial. All patients underwent cytoreductive surgery to clear all visible tumor. This was followed by HIPEC with gemcitabine for 60 minutes and systemic Decarbazine. Circulating tumor DNA was obtained at regular intervals after surgery, along with imaging, in order to monitor for disease recurrence. Included patients had recurrent ULMS and were deemed candidates for repeat surgery. We excluded patients who had recurrence within 6 months of receiving systemic gemcitabine or had ever been treated with Decarbazine in the past, as they would be less likely to respond well to the same drug. The primary endpoint was progression-free survival, and secondary endpoints were safety, recurrence-free survival at 6 and 12 months, and quality of life measures. So our preliminary results are based on the 13 patients enrolled so far. Median age was 55 years. All patients had excellent functional status with ECOG 0, and almost 2/3 had a history of morcellated tumors. All patients underwent 1 or 2 prior resection for their sarcoma, and most patients had undergone previous chemotherapy. At the time of surgery, the median peritoneal cancer index was 8, and all patients were able to achieve a complete cytoreduction. The median length of stay in the hospital was 6 days. This table shows the adverse events and complications by patient. As you can see, one patient had a grade 3 neutropenia that required treatment with Neupogen, and 2 patients had surgical complications. One was a bladder injury that was managed non-operatively, and the other was a ureteral injury that was identified intraoperatively and repaired. Of the 13 patients in the trial who have been enrolled, 69% have developed peritoneal recurrence at a median time of 7 months. All of these patients had positive ctDNA with recurrence, and it's actually correlated with their tumor burden. Most patients went back onto chemotherapy, often for multiple lines of treatment. Some underwent radiation, and all but one had repeat surgical resection. The other 31% had no peritoneal recurrence at a median follow-up of 18 months. One of these developed lung metastases, and the other 3 remain disease-free. They're all currently off treatment and undergoing surveillance, and all of their ctDNA levels have been negative. To date, the 6-month recurrence-free survival is 69%. I want to spend a moment to talk about circulating tumor DNA because it's a pretty hot topic right now. So it's a non-invasive test that detects molecular disease shed into the bloodstream. In our cohort, we used a tumor-informed platform, meaning we used the patient's own tumor tissue to develop a custom panel of gene mutations for that patient in order to monitor for their recurrence in their blood. And similar applications have been used in a variety of other cancers. For example, in colorectal cancer, ctDNA has been used after surgical resection to risk stratify patients and determine who is high risk and who may benefit from additional adjuvant chemotherapy. In our cohort, ctDNA has correlated very well with recurrence, which raises the potential that this could also be applied in sarcoma. This schematic shows the ctDNA levels and trends throughout treatment for one of our trial patients who had multiple recurrences and multiple resections. And as you can see, it actually correlates very well with tumor recurrence, and it comes down to 0 actually every time after the operation. Quality of life remains stable at 1 month before and after the HIPEC surgery, with slightly higher emotional scores post-op and slightly lower functional scores post-op. And again, this was at 1 month after big operation, so they may not have fully recovered to 100%. So again, uterine leiomyosarcoma is a rare sarcoma that has a high rate of peritoneal recurrence, even despite optimal surgery and maximal medical therapy. In our cohort, we show that CRS and HIPEC with gemcitabine appears to be safe, and patients are able to maintain a stable quality of life. It may also have the potential to improve peritoneal disease control, but it raises the question whether it is the aggressive surgery or the HIPEC that is truly benefiting patients the most. We also demonstrate that ctDNA can be used as an adjunct for disease surveillance. We're still in the process of accruing more patients with a goal of reaching 25. And of course, with more patients and longer follow-up, that'll enable us to better assess the efficacy of. Thank you, and happy to take any questions.